Here is a detailed explanation of aortic stenosis, covering each point comprehensively. 1. Introduction. Introduction. Aortic stenosis is a cardiovascular condition involving narrowing of the aortic valve, which obstructs blood flow from the left ventricle to the aorta and subsequently to the rest of the body. It is a progressive disease that can lead to left ventricular hypertrophy, heart failure, arrhythmias, and sudden cardiac death if left untreated. Most commonly seen in the elderly, AS is associated with significant morbidity and mortality. Early recognition and appropriate intervention can significantly improve patient outcomes. ASRA 2. Definition. Aortic stenosis is defined as the pathological narrowing of the aortic valve opening, which leads to an obstruction of left ventricular outflow during systole. As a result, the heart must work harder to pump blood through the narrowed valve, potentially causing structural and functional changes in the heart. HAR 3. Etymology. Aortic. Pertaining to the aorta, the main artery that carries oxygenated blood from the heart to the body. Stenosis, from the Greek word stenos, meaning narrow. Together, aortic stenosis refers to a condition involving the narrowing of the aortic valve. Narrative 4. Epidemiology. Affects 2 to 7% of adults over 65 years old. Men are more commonly affected than women. Degenerative, calcific aortic stenosis is the most common cause in developed countries. Rheumatic fever remains a significant cause in developing countries. With the aging population, the prevalence of AS is expected to increase globally. 5. Types of aortic stenosis. 1. Congenital aortic stenosis. Present from birth, often due to a bicuspid aortic valve. May become symptomatic in childhood or early adulthood. 2. Rheumatic aortic stenosis. Result of rheumatic fever leading to valve leaflet thickening and fusion. 3. Degenerative calcific aortic stenosis, most common in elderly, involves progressive calcium deposition. 4. Subvalvular aortic stenosis. Narrowing occurs just below the valve due to a fibromuscular ridge. 5. Supravalvular aortic stenosis. Narrowing occurs above the aortic valve, often associated with genetic syndromes, e.g. Williams syndrome. 6. Causes. Age-related calcific degeneration of the valve leaflets. Congenital bicuspid aortic valve. Normal valve has 3 cusps. Bicuspid has only 2. Rheumatic heart disease, leading to valve scarring and fusion. Radiation therapy to the chest, which may accelerate valve calcification. Infective endocarditis, rarely, leading to valve damage and scarring. 7. Risk factors. Advanced age, male gender, congenital bicuspid aortic valve, hypertension, hypercholesterolemia, diabetes mellitus, smoking, chronic kidney disease, rheumatic fever history of valve disease. #8. Complications. Left ventricular hypertrophy due to chronic pressure overload. Heart failure caused by poor left ventricular function. Syncope, often on exertion due to limited cardiac output. Angina, from increased oxygen demand of hypertrophied myocardium. Arrhythmias, especially atrial fibrillation or ventricular tachycardia. Sudden cardiac death. Infective endocarditis, damaged valves are more prone to infection. #9. Pathophysiology step-by-step. 1. Valve leaflet damage, due to aging, rheumatic fever, or congenital malformation. 2. Progressive narrowing, fibrosis and calcification cause reduced valve orifice. 3. Increased left ventricular pressure, more effort required to push blood through the narrowed valve. 4. Left ventricular hypertrophy, compensatory thickening of muscle to manage pressure. 5. Diastolic dysfunction, thickened myocardium reduces chamber filling. 6. Reduced cardiac output, as heart struggles, forward flow decreases. 7. Myocardial ischemia, demand outweighs supply, leading to angina. 8. Pulmonary congestion, blood backs up into the lungs, causing dyspnea. 9. Heart failure, ventricular function eventually declines. 10. Signs and symptoms, exertional dyspnea, difficulty breathing during activity. Chest pain, angina, due to decreased coronary perfusion. Syncope, especially during exertion. Fatigue and weakness, palpitations, dizziness, heart murmur, harsh systolic murmur radiating to the neck. Signs of heart failure, orthopnea, paroxysmal nocturnal dyspnea, peripheral edema. 11. Diagnosis, physical examination, systolic ejection murmur at right upper sternal border. Echocardiography assesses valve area, gradient, and left ventricular function, shows signs of left ventricular hypertrophy. Chest X-ray may reveal calcification or cardiomegaly. Cardiac catheterization measures transvalvular pressure gradient. CT MRI helps assess valve anatomy and calcification. Nursing diagnosis, decreased cardiac output related to obstruction of blood flow, activity intolerance related to fatigue and exertional dyspnea, risk for decreased tissue perfusion related to reduced cardiac output, anxiety related to potential for surgical intervention, knowledge deficit regarding condition and management. 13. Medical management, symptom monitoring. For patients with mild or moderate AS, medications, primarily symptomatic relief, diuretics, for fluid overload, use cautiously, beta blockers, to reduce myocardial oxygen demand, ACE inhibitors, for hypertension and heart failure management, statins, may help slow disease progression, controversial, avoid excessive preload or afterload reduction. 14. Nursing management, monitor heart rate, blood pressure, and respiratory status, assess for signs of fluid overload, edema, crackles, educate patient about activity limitations and symptom monitoring, ensure oxygen therapy if indicated, provide emotional support and reduce anxiety before surgical interventions, encourage adherence to medications and follow-up appointments, prepare patient for surgery or diagnostic tests as needed. NASHA 15, treatment options. 1. Surgical aortic valve replacement, SARE. Open heart surgery to replace valve, recommended for symptomatic patients or those with severe AS. 2. Transcatheter aortic valve replacement, TAVR. Minimally invasive, suitable for high-risk or elderly patients. 3. Balloon valvuloplasty. Temporary relief, more common in younger patients or as a bridge to surgery. 4. Medical therapy, palliative only, cannot reverse stenosis. 5. Antibiotic prophylaxis, for prevention of infective endocarditis during dental procedures. 16. 5 psychosocial interventions. 1. Patient and family education, explain disease progression, treatment, and lifestyle changes. 2. Coping skills training, help manage stress, anxiety, and emotional burden. 3. Support groups, encourage participation in cardiac patient communities. 4. Preoperative counseling, prepare patients emotionally and mentally for valve replacement. 5. Postoperative emotional support, monitor for depression or anxiety and offer mental health referrals as needed. ANA 17. Prevention, treat streptococcal infections early to prevent rheumatic heart disease. Manage blood pressure and cholesterol levels effectively. Avoid smoking and excess alcohol. Regular checkups for at-risk individuals, especially elderly. Maintain a heart-healthy diet and engage in some safe physical activity. 18. Conclusion. Aortic stenosis is a common but serious condition that can significantly affect cardiac function and overall quality of life. Early recognition, risk factor control, and timely intervention, particularly surgical or transcatheter valve replacement, are key to preventing complications. Nurses and healthcare providers play a critical role in education, symptom monitoring, emotional support, and preparing patients for surgical procedures. A multidisciplinary approach ensures optimal management and improved patient outcomes. Thank you. Have a nice day.